This session is being sponsored by BDR, and in this session we would be discussing about the role of enzalutamide in the treatment of metastatic CRPC. Now, over last 10 years, in the last decade, enzalutamide has established itself as a very important molecule in the treatment of prostate cancer. The use of this molecule began in metastatic CRPC setting, but now if we look as a whole, this molecule is being used not only in second line setting mCRPC, it is there in first line. Now it is there in metastatic hormone sensitive setting as well. And it is also there in the non-metastatic CRPC setting as well. So virtually it is there as a part of systemic treatment option in all stages of prostate cancer management. But I would be discussing and keeping my talk limited to the metastatic CRPC setting. Next slide, please. So, enzalutamide, as we know, it's a very potent androgen receptor inhibitor, much more potent than bicalutamide. It blocks the androgen receptor directly. It also inhibits the translocation of androgen receptor down to the nucleus, and it also inhibits the interaction of that receptor with the DNA. So it is acting at 3 different levels, much different from the bicalutamide, and that's the reason why it is much more potent. Next slide, please. So when it came in capsular form, 40 milligram capsules, but over last few years it has come in 80 milligram as well, and now very lately it is available in 160 milligram as well. The dose is 160 mg OD, so it has become much more easier for our patients, at least when the 80 milligram came, and now with 160 milligram, the compliance might still be better. Next slide, please. So it is largely metabolized by the liver enzymes, CYP3A4 and 2C8 system. Next slide. Right. So coming to my talk, I have divided my talk into 3 aspects. In the first aspect, I will discuss about the role of enzalutamide in the treatment of mCRPC in the post-docetaxel setting. In the second part of my talk, I'll be discussing about the role in the pre-docetaxel setting. And in the third part, I would be discussing about how to sequence this agent with respect to the commonly used chemotherapy agent, that is docetaxel, and how to sequence this with respect to abiraterone in the mCRPC setting. So in the first part, the entire story began with this large phase 3 trial, the AFFIRM trial. It was a 1200 patient trial done in post-docetaxel treated metastatic CRPC patients. These patients were randomized to receive enzalutamide 160 milligram per day versus placebo in a 2:1 randomization. So 800 patients received enzalutamide and 400 received placebo. The primary endpoint of this study was overall survival. Next slide, please. So, this was a very hard endpoint, overall survival, and the patient number in this trial was much more than the previous trials of docetaxel in the similar setting. 1200 patients were included. And what this trial showed was that in the arm which received enzalutamide, the median overall survival was 18.4 months. And in the arm which received placebo, it was much less at 13.6 months. So an absolute improvement of 5 months in overall survival, and with a hazard ratio of 0.63. Now, if we would recall docetaxel, which was the first agent to be approved in mCRPC setting, it improved the survival to the tune of around 2 months. Now, this agent in a previously treated CRPC population, that is it's resistant to docetaxel. This molecule showed an absolute improvement of 5 months in overall survival. And because of this, and this came a decade back, and this got approval by US FDA to be used in this type of patient population. Next slide, please. not only the primary endpoint, but also the other secondary endpoints, including the PSA decline, including the median time to PSA progression and the median radiographic PFS, all favored enzalutamide and by quite a distance. Next slide, please. Now, with regards to toxicity, it is interesting to note that as compared to placebo, the adverse event incidence was almost the same. In fact, if you would see that few of the adverse events were in fact less with the use of enzalutamide than compared to placebo. So one point to highlight about using enzalutamide is that there is an increased propensity to cause seizures, and that is one history which we always take in our patients before we start enzalutamide. In this initial trial, 5 patients developed seizures who were on the enzalutamide arm. So, I mean, at the end of the day, it was only 0.6% of the entire trial population. But this has been highlighted that patients with underlying seizure disorder should avoid using enzalutamide. Next slide. Now, coming to the second part of my talk, taking the story forward and the benefits derived by the use of enzalutamide in CRPC. The phase 3 trial Prevail was conducted in patients who had not been previously treated with docetaxel. So patients these were mCRPC, these were asymptomatic or mildly symptomatic, but they were chemotherapy naive. Again, a very large trial, 1,717 patients randomized to receive enzalutamide 160 mg per day versus placebo. Again, very hard endpoints of overall survival and radiographic progression-free survival. Next slide. Now, with regards to the adverse events, even in this setting, we find that it is largely well tolerated as compared to placebo. The side effect profile is almost similar with respect to the common effects, like, for example, fatigue, pains, which are many a times related to the prostate cancer itself. Some effects which are related to anti-androgens, for example, hot flushes, which were more in the enzalutamide arm. And just to highlight here that acute coronary syndrome, there were 7 patients who developed acute coronary syndrome in the enzalutamide arm, and there were 4 in the placebo arm. So a very slight increase in the incidence of coronary syndromes with the use of this molecule compared to placebo. Next slide. From this study, it was found that even in the pre-docetaxel setting, this molecule resulted in a significant improvement in the primary endpoint of radiographic PFS. The hazard ratio was 0.19, and in terms of improvement in overall survival, where the hazard ratio was 0.71. Next slide, please. So, in fact, this is one of the trials in oncology which was halted in between simply because the investigator arm resulted in such a significant benefit, then it was found to be unethical to continue the placebo arm. So the trial was halted, it was unblinded, the data was reported, and the patients who were on the placebo arm were actually offered enzalutamide because of the stark improvement in overall survival. So this was one such instance. And because of this fact, enzalutamide got FDA approval to be used in metastatic CRPC patients who were asymptomatic or mildly symptomatic and who were docetaxel naive. Next slide. So these are the conclusions which I just enumerated. Enzalutamide in this setting resulted in reduced risk of death, delayed metastatic progression, achieved clinically meaningful responses in soft tissue disease, delayed time to cytotoxic chemotherapy, delayed deterioration in quality of life. So it was acting on virtually all the secondary endpoints as well. Next slide. So just to summarize the role of enzalutamide and the way we have used this molecule for last almost 6-7 years in our practice, it did achieve improvement in overall survival. In the post-docetaxel setting, it was around 5 months. In the pre-docetaxel setting, it was around 4 months. So very important molecules. Just make sure that we do ask about the history of seizures before recommending this molecule to our patient. Next slide. So coming to the last part of my talk, which is about how to sequence this molecule. Now we know that there is availability of abiraterone, there is availability of docetaxel, cabazitaxel. These are the molecules which we very routinely use. And now, as Dr. Jyoti enumerated, that there is a plethora of newer agents coming up on the PARP inhibitor front and on the immuno-oncology front and on the combination of these agents front. So the treatment decision making is going to become more complex. Now, keeping it simple for the time being, uh, just let me discuss about this point about sequencing of enzalutamide. Next slide. Next slide, please. Yeah. So this was a systematic review of 13 published retrospective studies in mCRPC, around 1,000 patient study. And all these 1,000 patients had received docetaxel for the CRPC in the CRPC state. And these patients, all these patients received cabazitaxel and one of the androgen receptor agents. Now, from this study, they concluded that sequencing one AR axis agent, that is enzalutamide followed by abiraterone or abiraterone followed by enzalutamide, should not be done or should be avoided as far as possible. This is because if we expose these patients to one of these agents and another agent should be cabazitaxel, such patients do achieve a better overall survival. So if we were to look at the entire journey of these patients, and especially those who have received docetaxel as their first line agent in CRPC, they should receive cabazitaxel and one of the agents, either abiraterone or enzalutamide, during their journey. And if we are able to achieve that, we would be able to ensure longer survival for our patients. Enzalutamide followed by abiraterone or abiraterone followed by enzalutamide should be avoided as highlighted in the red curve here as far as possible. Next slide. Now, what are the response rates if suppose we do have to use these agents in sequence, and many a times we do use these agents in sequence simply because some of our patients are not fit to receive chemotherapy, and we are left with very limited choices, and so we do have to sequence them. So if we were to sequence them, then enzalutamide followed by abiraterone results in a very dismal response rates to the tune of around 3 to 8%. However, abiraterone followed by enzalutamide results in a slightly better response rates ranging from around 10 to 30% range. So if we were to sequence them, the sequence should be abiraterone followed by enzalutamide. Again, a retrospective analysis or an analysis from studies and patient groups, but this is the best we can get. And this point was also highlighted by Dr. Jyoti in one of the clinical trial setting also. The sequence, if at all it has to be used, abiraterone followed by enzalutamide. Next slide. Now, another question which came to our mind was what happens if we can combine enzalutamide and abiraterone. We know that these molecules have separate mechanism of action, and would it be beneficial if we can combine these two? And this question was answered by this study which was published in JCO way back around 4-5 years back. So enzalutamide plus abiraterone versus placebo plus abiraterone, and it showed that there was no significant advantage of combining these two agents. Next slide. Another database, the CATS International Database, trying to answer the question of sequencing. To summarize this database of around 700 patients, the end point is that patients in metastatic CRPC setting should receive docetaxel, if possible should receive cabazitaxel, and if possible should receive one of the agents, either enzalutamide or abiraterone, in their journey. And if we are able to expose these patients to these three agents, we would be able to achieve uh, good outcomes for our patients, or the best possible outcome for our patients. Next slide. Yeah, next slide. Next slide. Right. So as I said, and in amongst so one important point which came out from this additional point was that between docetaxel and enzalutamide, it is preferable to use docetaxel first, and not because we are medical oncologists, but there is some data to suggest that if we are using docetaxel first, these patients do live longer. And again, inference derived from retrospective analysis, but we can see here that those who receive docetaxel upfront, followed by enzalutamide and cabazitaxel, they did better than those who received hormonal agents first, followed by docetaxel. Again, a retrospective. Next. So to clear out some of the confusion regarding the sequencing, let me just say that whenever one androgen axis agent is prescribed after another androgen axis agent, the outcome is generally poor. The response rates are quite dismal. If at all we have to use these agents in sequence, it is better to use abiraterone followed by enzalutamide. In that case, the enzalutamide response rates are better, to the tune of around 10 to 30%. There is no benefit of combining these two agents. It doesn't result in improvement in survival outcomes. Docetaxel, wherever possible in CRPC setting, can be used upfront. Again, not a direct comparison with these agents, but from the retrospective analysis, we know that the activity of docetaxel is somewhat reduced if it is used after androgen axis agent. So, advisable to use docetaxel up. The activity of cabazitaxel is, however, not reduced. And sequencing will become more complicated as number of patients who receive abiraterone or docetaxel in the hormone sensitive setting, and now even the enzalutamide has come in the hormone sensitive setting. So as these molecules shift into hormone sensitive setting, and with the availability of more combinations now which are being tested in clinical trials, it is going to become more complex. So with this, I'll conclude my talk. Thank you, organizers, for having me here.